Thank you for joining us for today's webinar, Osteoporosis and the Female Patient Post-Menopause. My name is Jessica Monmany, and I am the Senior Education Associate at ARHP. I will be moderating today's webinar. Before we begin, I would like to share how you can receive continuing education credits for this webinar. In order to receive credit, you must take the pre- and post-test. If you have not yet taken the pre-test, please click the link provided to you in the reminder email or via the webinar's chat box. You can also use this box to enter questions throughout the webinar, which will be answered by our presenter at the end. About an hour after the conclusion of the webinar, you will receive an email from Caitlin Borsowitz, ARHP's Communication and Education Associate, with a link to the post-test survey. Your continuing education certificate will be generated upon completion of that survey. In 4 weeks, you will receive another email with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you've incorporated what you've learned during this webinar into your work. Completing the pre- and post-test, as well as this follow-up evaluation, helps ARHP ensure we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. At this time, I would like to introduce Dr. Jeffrey Levine, today's presenter. Dr. Levine is Professor and Director of Women's Health Programs in the Department of Family Medicine and Community Health at Robert Wood Johnson Medical School in New Jersey. He is also a professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences, as well as co-chair of the North American Committee on Continuing Medical Education Women's Health Forum. Dr. Levine has co-authored numerous women's health-related articles, monographs, and book chapters. Dr. Levine was the first appointed chair of the New Jersey Department of Health and Senior Services Interagency Council on Osteoporosis. He devotes much of his time to teaching students, residents, and fellows. In 2005, Dr. Levine was selected as UMDNJ Master Educator in recognition of his outstanding contributions to medical education. Dr. Levine's full bio is available on ARHP's webinar web pages. We're thrilled to have him with us today, and I will hand it over to him. Dr. Levine, you have the floor.
Thank you, and welcome everyone. I really want to thank you all for taking time out of your busy schedules to participate in this webinar, and I think you'll agree is a topic so important to women's health. And I know we have women's health practitioners from all different professions and specialties with us today, and I think hopefully all of you will find benefit to it. And I want to remind you that this program was made possible through a medical education grant from Allergan. Now, I manage, these are my disclosures, I manage issues regarding bone health both for men and women of all ages as a family physician, but especially postmenopausal women. So this is not only an issue that I'm very passionate about professionally, but personally as well. My mother actually suffered multiple vertebral fractures from steroid-induced osteoporosis. So I come at this from both a personal and professional background. And what I really hope is at the end of this webinar that I'm going to enable you to help identify the risk factors for osteoporosis in your patients, to help you be able to screen your patients appropriately for postmenopausal osteoporosis in your postmenopausal women, and to diagnose postmenopausal osteoporosis, and to be able to objectively discuss prescription therapy options for your patients who meet the criteria for prescription treatment, and also to really promote non-pharmacologic strategies for all your patients. Now, we're going to really focus on the postmenopausal woman, but we actually do have another module for osteoporosis in the premenopausal patient that you can refer to through ARHP as well. This is obviously a very common condition, whether you treat women or men. About 1 in 3 women and about 1 in 5 men over 50 will sustain a fracture due to osteoporosis. And unless you're planning on retiring anytime soon, with the aging of the baby boomer population, these numbers are just going to increase, both in patients who have osteoporosis and low bone mass, or as we say, osteopenia, but also who suffer the consequence in terms of fracture. And the one that we're most concerned about and most ominous are hip fractures. And about 3/4 of hip fractures related to osteoporosis occur in women, and up to 25% of those women can suffer mortality if you rule out other causes. Just related to hip fracture, about 25% can die within a year after a hip fracture, and those who survive often have significant morbidity. So certainly very important to address with our patients. Now, in it's not just an issue for postmenopausal women, but all of our patients, because bone mass pretty much accrues, most of it by age 20, and pretty much totally maxes out by about age 30. So in our younger patients, we really want to emphasize getting enough nutrition, including calcium, vitamin D, and protein, making sure they're being physically active, avoiding things like alcohol and smoking that can have significant impact on their ability to peak their bone mass. And those are things we want to sustain with patients as well after age 30 and to the postmenopausal period. Now, when we look at risk factors for osteoporosis, it's not just for postmenopausal women, but men as well. Far and away, the #1 risk is age. As we get older, for both men and women, their risk of osteoporosis with subsequent fracture increases. Men tend to be born with more bone mass and peak bone mass a little higher, so being female does put them at slightly higher risk earlier. Also, men don't go through menopause like women do, where they can lose up to 20–30% of their bone mass during that 3 to 5 year period. But basically, by about age 70, men tend to catch up, and you start seeing men fracturing at the same rate as women. Certainly, having a family history of osteoporosis, particularly a mother or father who suffered a hip fracture, puts you at much higher risk. If you've had a previous fracture, particularly men and women who have suffered a vertebral fracture are at a much higher rate, even within a year of suffering another fracture. Being African American, those women tend to have higher bone density, but that doesn't mean that they're not at risk. So ethnicity should not affect who you screen. But understanding that menopause is probably one of the second most important, next to age, risk factor for postmenopausal women, because estrogen deficiency is often what drives that loss in terms of bone density. So understanding not just natural menopause, but particularly women who've gone through premature menopause, it's not hysterectomy, but actually if they've had oophorectomy, if they had their ovaries removed, those women are at a very high risk of losing bone over a very short period of time. Steroids, we probably all have patients that we prescribe steroids for different conditions, but even just 5 milligrams or its equivalent of prednisone for only about 3 months, and that's cumulative, can accelerate bone loss. Steroids increase bone breakdown, inhibit calcium absorption. So those are why steroids are very, very significant risk factor for bone loss. Medical conditions such as rheumatoid arthritis or hyperparathyroidism or low testosterone states in men, or again, very low estrogen states in women, put them at a high risk of not only developing osteoporosis, but subsequent fracture. And unfortunately, those are a lot of things that we can't necessarily modify, except maybe trying to get patients off their steroids or treat their conditions as best as possible. But there are certainly ones that we can try to help our patients modify, such as alcohol intake. More than 1 glass of alcohol for women or 2 glasses for men has been shown to accelerate bone loss, and also tends to decrease their ability to get adequate protein and calcium in their diet. Active smoking. Smoking does so many bad things. This is just another one. Not only stimulates bone breakdown, it definitely is another risk factor. Also, being low body weight. Particularly our patients who might suffer from female athlete triad or other eating disorders, but even patients who just genetically are of a smaller body frame might be at a higher risk. And certainly poor nutrition states, whether it's adequate calories, protein, vitamin D, or calcium, are certainly important, and that's why it's also important to screen for eating disorders. And also our patients are couch potatoes, those who don't exercise regularly. Also, exercise has a direct and indirect effect on not only bone density, but flexibility and risk of falls. Patients that are prone to falls themselves don't increase the disease of osteoporosis, but certainly the consequence in terms of you're not likely to fracture your hip unless you fall. So there are recommendations that we should be encouraging or promoting to all of our patients, both men and women of all ages. And #1 is making sure they're getting adequate amount of calcium and vitamin D. Now, you probably heard a lot of controversy recently about calcium and potential cardiovascular events. There is a lot of controversy about this, but I will tell you from my standpoint, I almost always try to emphasize food sources of calcium first. The current recommendations are that premenopausal adult women should probably get about 1,000 milligrams of calcium a day, and postmenopausal women about 1,200 milligrams. And again, there are many food sources, both dairy and non-dairy, that can give you up to probably 300 milligrams a day. So for most patients, I'm able to get them at least 3 servings a day, get them about 900, 1,000, and then try to just make up the difference with a supplement, no more than 500 milligrams a day. Regardless of whether the evidence is true about cardiovascular risk, we do know that excessive calcium supplements increase your risk for kidney stones, and I don't know of any calcium supplement that provides protein like dairy sources, and protein is one of those hidden nutrients people forget about, very important for bone health. So again, 1,000 milligrams for premenopausal women, 1,200 milligrams for postmenopausal women. Food, fortified foods, and only make up any difference with supplements, and really no more than 500-600 milligrams of calcium. I usually recommend calcium carbonate. It's cheaper for patients. You get more per pill, but you must take it with food. If they're on PPIs or have stomach acid issues, then calcium citrate can be taken regardless of food. The second is vitamin D. Current recommendations are about 800 international units a day for postmenopausal women and older men, and the reason is it's very hard to get vitamin D in food sources, so supplementation is recommended. Vitamin D is very inexpensive, and it's very hard to overdose, so that's generally something that should be recommended to your older patients, your postmenopausal women, older men. There are ways to get adequate sunlight and other sources of vitamin D in younger patients. We shouldn't be screening every patient for vitamin D, but we'll talk later about how to do that in patients who might be at risk, and certainly patients with a diagnosis of osteoporosis. You also want to encourage weight-bearing or strength training exercise. So swimming is excellent aerobically, but not great for bones, but there are aqua aerobic classes for patients with bad knees that will stimulate bone. Any kind of jumping exercises, Zumba, etc. Weight training has been shown to not increase bone density a lot, but it does somewhat, but what it really does is prevent bone loss, and again, improves flexibility and balance, and leads to prevention of falls. Obviously, counseling patients about strategies we'll talk about later to prevent falls. If you have patients who don't smoke, encouraging them not to, and patients who do smoke, encouraging them to stop. And again, understanding a little of alcohol may be beneficial to the heart or to the brain, but excess amount is bad for both the heart, the brain, and also bone as well. And we're going to talk later about FDA-approved medications for osteoporosis, but very important, those medications, none of them are approved for premenopausal women. I encourage you to go to that other module to learn more about management of low bone health or poor bone health in premenopausal women, but the medications are not recommended in that population. So when we decide on which patients to screen, you really want to look at patients, all women 65 and over. Medicare will cover bone density tests for all women 65 and over at least every 24 months. So you can assume that all women over 65 are estrogen deficient. That's an adequate risk factor to screen them. But if we only screen women over 65, we're going to miss a lot of cases of osteoporosis in younger women, and a lot of women fracture under that age. So, but if we screen every woman, we're going to do a lot of unnecessary testing. So current recommendations are, if you have a postmenopausal woman who's under 65, who either suffered from premature menopause, either through chemotherapy, genetic reasons, or had an oophorectomy, had their ovaries removed, those are patients who are going to be estrogen deficient at a younger age. They should be screened. If their mother or father suffered a hip fracture, those are patients who should be screened. If you have a patient who had a personal history of it's called a non-fragility fracture. In other words, they were standing or sitting and fell, not in a high-speed motor vehicle accident, and they fractured. As long as we're not talking about fingers, toes, or skull, those are not considered bones associated with osteoporosis, but any other fractures, ribs, pelvis, wrist, spine, those are patients who should be screened. Patients who are known to drink excessively alcohol or are current smokers should be screened. Patients who are either currently using steroids or have used steroids, at least 5 milligrams of prednisone 3 months or more, whether you're asthmatic, you're inflammatory bowel, rheumatologic patients. And patients who suffer from certain medical conditions like hyperparathyroidism, which accelerate bone loss significantly. Those are all conditions recommended that those women should, postmenopausal women under 65, should be screened with a bone density test. There are also your breast cancer patients who are on aromatase inhibitors, these new medications that totally wipe out their estrogen stores. Those are patients who should be screened. If you have patients on thyroid hormone, but they're hyperthyroid, they've been taking excessive amounts of thyroid hormone, or they have true hyperthyroidism, those are also patients. So there are certain medical conditions and medications that accelerate bone loss, along with the lifestyle issues and personal family history, that by getting a good history, you can direct which are my postmenopausal women under 65 that I want to refer for screening. Obviously, if you have a patient who has unexplained back pain, shortened height, those are all signs on your exam that might prompt you also to screen a patient. When we refer patients for screening, we're talking about central DEXA or dual X-ray absorptiometry. That's considered the gold standard for screening patients for osteoporosis. And we usually measure their hip and their vertebral spine, because their hip was the area we're most concerned about. The spine, also the area that tends to lose bone the most, and also a concern. So you usually want to measure at least 2 sites, at the hip and spine ideally. If you have patients who have very bad scoliosis, or they've had bilateral hip replacement, or very bad arthritis in the spine, you can actually use the distal radius, or the wrist, as a surrogate marker and have still 2 sites, either hip and wrist or spine and wrist, if you can't just do hip and spine. And this is basically what we look for, is how many standard deviations away on their DEXA are they from a control group of young adults, usually women who have peaked their bone mass around age 30. So it doesn't compare your patient to someone else. They're saying that they're 56 to another 56-year-old, but to someone at their peak bone mass. And how many standard deviations are they away on their bone density? If it's less than 1, it's considered normal. Between 1 and 2.5, they have what's called low bone mass, or we often refer to as osteopenia. But if they're more than 2 standard deviations below that, that's considered osteoporosis. And if they are below that but also have suffered a fracture of their spine or hip, that's considered severe osteoporosis. And what we use for standard deviations is something called a T-score. So for every standard deviation your patient is away from that control group, they are a -1 T-score. They're 2 standard deviations, -2, and so on. And the T-score is what we tend to use for postmenopausal patients, and it's used for making a diagnosis of either normal, osteopenia, or osteoporosis. There is another score called a Z-score that you'll often see on bone density reports, and that compares your patient to someone of their same age. You don't use that for diagnosis. That's really used more for premenopausal patients, and it's very rare conditions like female athlete triad or anorexia that you would be getting bone density in those patients. The one area where a Z-score could be helpful is if you have a patient with osteoporosis and their Z-score is more than 2 standard deviations below their age-matched control. That's a signal that you should be doing secondary testing for secondary causes. But that, to be honest, is something I recommend in any patient you diagnose with osteoporosis, before you start them on any kind of prescription therapy. So again, you have a patient, you perform a bone density test, measuring their hip and spine ideally, because that correlates best with bone strength, and it's the best predictor we have of their fracture risk. If you have a patient who's diagnosed with osteoporosis, either their DEXA is -2.5 or lower, or they meet other criteria for treatment, I always recommend that you exclude secondary causes for osteoporosis. I do a CBC. I want to look for, is there a sign of malnutrition, severe anemia, or malignancy that could be contributing to their bone loss? I want to test their kidney function. Do they have renal insufficiency, liver diseases that can affect it? Also, I want to make sure, is their calcium elevated? Do they have possible hyperparathyroidism or other celiac sprue or something else that may be causing their bone loss? Also, it's important to measure kidney function because that can determine what medications you can or cannot use. I tend to only do a serum TSH if the patient has symptoms of hypothyroidism, but some would advocate doing it anyway because, as I mentioned before, hyperparathyroidism, whether it's idiopathic or iatrogenic, is certainly a risk for osteoporosis. I also check a serum, and that should be 25 hydroxyvitamin D. That's the storage form of vitamin D. Whenever you're screening patients for vitamin D deficiency, you actually measure 25 hydroxyvitamin D. Some use a cutoff of under 20 for insufficient, but if you have a patient who already has a diagnosis of osteoporosis or significant bone loss, anything under 30 is usually considered insufficient. You also, it's a very easy, inexpensive test, but often hard to get patients to do, is a 24-hour urine for calcium. You want to know, are they hyper-excretors? Is there a sign that they might have hyperparathyroidism? Or are they excreting very low amounts? Do they have vitamin D deficiency? Or maybe they have celiac sprue. So these are not very expensive, pretty easy tests to get that I think are very important to obtain before you initiate treatment in any of these patients. Because if you don't correct their underlying secondary cause, then any medication used probably will not be effective. Now there are, you may have heard in the news, what about using bone markers besides doing a bone density test? And it's very important to understand in clinical trials these bone markers were used very often, but they are not useful for making a diagnosis of osteoporosis. If you have an athlete who's using steroids, they're going to have a lot of bone turnover. Their bone marker will be very high, but they don't have osteoporosis. If you have a frail 80-something-year-old patient, her bone marker test will be very low. She has very low bone turnover, but she already has significant bone loss. So it's not useful for making a diagnosis, but there is some practicality to using it, and that is in monitoring your patients. If you have patients who you initiated treatment and you want to know, you don't want to wait 2 years to get their other bone density, or the patient's like, I don't have any symptoms, these are expensive medicine, how do I know the medicine's working? Or you're not sure if the patient's being compliant with the medication. Maybe their bone density continues to decrease and it's not clear whether or not they're taking the medicine properly. These markers can be very helpful, and basically what you do is you want to check a serum CTX. The urine tests are not as reliable. It's a blood test. You try to get it first early in the morning on that patient fasting. And if you get that at a baseline and then recheck it 3 to 6 months later, and you see a 30 to 50% decline in those patients' CTX, that is a very good sign that their medication is working. If they're on what we'll talk about later, anti-resorptive therapies, medicines that are designed to decrease bone turnover. So that's where I find utility in those, but should not be, again, used for making a diagnosis with your patients. If you have a patient who stops treatment and you want to follow, is their body starting to increase bone turnover? That's another way. If you start seeing an increase in that marker, that could be a sign that you need to put them back on medication. So let's do a case that I think hopefully will illustrate some of the concepts that I've been talking about. We have Roberta. She's 59 years old. She's about 8 years postmenopausal. She's not currently having any hot flushes or night sweats, but she's been watching advertisements on TV for osteoporosis medications, and she wonders, should I be on these medicines? Am I at risk? So she comes to see you, and she does mention that she does exercise pretty regular. She's not a smoker. She doesn't drink a lot of alcohol. She does take a calcium supplement, but she doesn't really get a lot of calcium or vitamin D in her diet. She doesn't take any vitamin D supplement. And she does note that her mother suffered an osteoporosis-related hip fracture in her 70s and wound up being wheelchair-bound in a nursing home. And that's something she's worried about and doesn't want to wind up like her mother. So because that Roberta is postmenopausal, even though she's under 65, she does have a first-degree relative who had an osteoporosis-related hip fracture. I think you would agree with me that she's a good candidate to send for a bone density test. So you do obtain the test, And again, you get her spine measured and her hip measured. And usually when they measure the spine, they try to get all four out of the 5 lumbar sites, L1 through L4. And they take a composite of that and give you a T-score. And in Roberta's case, it's minus 2.1. When you look at her hip, they tend to measure both hips if possible. They measure not only the femoral neck, but the total hip. And what you want to do is you want to look at both the spine score, the hip score, both the total hip and femoral neck. And you make your diagnosis based on the lowest measured site. So if you look at Roberta, her L1 through 4, her spine measurement is minus 2.1, which is lower than any of her hip measurements, but none of them are minus 2.5 or lower. So Roberta does not have osteoporosis, but she doesn't have normal bone density either. She has what's called low bone mineral density or osteopenia. So what does that mean clinically for Roberta? So if you were to get these results back, that Roberta, based on her DEXA, has osteopenia, not osteoporosis, but not normal, are you going to recommend, say that her DEXA results meet clinical recommendations for pharmacologic treatment? Her DEXA results confirm she does not have osteoporosis, so she does not require pharmacologic treatment? Or are you going to say, I would perform a FRAX? Or you might be asking me, what the hell is a FRAX? Or you're really not sure what to do. So I believe you have an opportunity now to select one of these, and then we're going to have an opportunity to look at what the fellow participants selected and discuss this in more detail. So please make your selection now. Okay, so what I see here is about 23% of you said I perform a FRAX, and about an equal number of you said you're not sure, which is good. That's why you're on the webinar, and hopefully I'm going to help you with that. And actually, the majority of you, small majority, said that she doesn't have osteoporosis, so you're not going to treat. So, but we have some with pretty much every answer. So let's go through this in more detail. When we measure bone density, remember what I said, it correlates very well with fracture risk. So the lower your bone density, the more negative, as you see in this illustration with the yellow bars, the higher your risk for fracture, or the higher the fracture rate. So obviously you'd say, well, okay, so the lower a patient's bone density, the higher their rate. We should only be treating patients with osteoporosis who have a T-score of minus 2.5 or lower if you look at the yellow bars. The problem is, if you take all postmenopausal women who undergo DEXA who have risk factors, more of them actually fracture in the osteopenic range, that minus 1 to minus 2.5. So if we only treat patients who have the diagnosis of osteoporosis, we're going to miss a lot of fractures. But if we wind up treating everybody, that's going to create a lot of cost and unnecessary side effects. So it's obvious if you have a patient who has osteoporosis, you need to treat with medication. But how do you select out those patients in between in that osteopenic range, or just follow? And the current recommendations is if you have any patient who meets the criteria for osteoporosis at the hip or the spine, you treat. That's if it's at the femoral neck, the hip, or the spine, regardless. The lowest site, you exclude secondary causes, as I mentioned, those lab tests that I recommended, and you initiate prescription pharmacologic therapy. But if you have a patient who's in that osteopenic range and they have a FRAX score, their 10-year risk of a hip fracture is more than 3%, or their 10-year risk of a major osteoporotic fracture, like a symptomatic vertebral fracture, is more than 20%, you treat. So how do we make sense of this? How many of you use the Framingham, the cardiovascular, or the American Heart Association cardiovascular risk calculator in your practice? Maybe You want to help patients understand what is their risk for a cardiovascular event in the next 10 years. And the reason many of us use that calculator is to help determine which patients should go on cholesterol medicine or which patients we can just follow with diet and exercise, or which patients we should be recommending aspirin and which ones we should not. So it has a lot of clinical utility when you can take patients' individual risk factors and make a determination who to treat and who not with pharmacologic therapy, whether it be aspirin or statins. Well, the same holds true with what's called the fracture risk assessment tool. Very similar to the cardiovascular risk tool, it looks at certain characteristics of your patient who's in front of you, their age, whether they have a history of a fracture, whether their mother or father suffered a hip fracture, whether they've been currently on steroids or have a cumulative history of steroid use, whether they're currently a smoker, whether they consume excess alcohol, or whether they have a diagnosis of rheumatoid arthritis. And basically, what you do is you go onto this website, so you can Google this. There's actually an app. If you go on to your app store for Frax, and you can get this onto your iPhone, or you simply go on the computer, you Google Frax, and this will come up. And what you first want to indicate is which country do you practice in, because different countries use different cutoffs of when to treat a patient. So for instance, Roberta was white and you're practicing in the United States, so you would click U.S. Caucasian. If the patient was African American, Hispanic, or Asian, you would pick different. Then you're going to get this little chart here, and you're going to enter information that we know about Roberta. We know she's 59 years old. We have her weight. You enter it into pounds and in her height in inches, and it will convert it, fortunately, for you into kilograms and into centimeters. Then you're going to document whether or not she had a prior fracture. Roberta didn't report having a prior fracture, so you'd say no. But her mother suffered a hip fracture. You're going to check off yes. Is she a current smoker? No. Has she been on steroids? No. Does she have other signs of secondary osteoporosis? No. And does she drink excessive amount of alcohol? No. And if you were just to do that, even without her bone density, you can get a 10-year probability of what her risk is for either a hip fracture or a major osteoporotic fracture. But we do know her bone density, and you can either put it in her left femoral neck, her score, and you put in the T-score. You've got to remember to put a minus sign, otherwise it's going to change your answer. Or you could just put in her total BMD, which is like 0.876. So you enter that information, and lo and behold, you'll get a more accurate indication of what her 10-year fracture is. For younger patients, even if you don't enter the bone density, it may be similar, but as patients get older, it's more and more important that you enter their bone density into the calculation. And as you can see, her risk for a major osteoporotic fracture is 15% in the next 10 years, and for a hip fracture, 0.8%. And what we've determined in the United States is the cost per quality of life for hip fracture or a major fracture is that if you have a risk of a hip fracture of more than 3% in the next 10 years, or of a major osteoporotic fracture greater than 20%, then it's cost effective when you control for cost, side effects, and benefit to treat those patients. So to recap, based on the Frax, Roberta would not be recommended for treatment because she's not osteoporotic, she's osteopenic, and her 10-year Frax risk is less than 20% for a major osteoporotic fracture and less than 3% for a hip fracture. But you remember, with any of these calculators, it's garbage in, garbage out. If Roberta says, oh, I forgot, I had a hip wrist fracture, I slipped on the ice and I fell and broke my wrist. Well, that changes what we would enter. So if we now change her no to a yes for previous fracture and recalculate her risk, look at this. She now has a major osteoporotic risk of 25% in the next 10 years. Her hip fracture risk is still less than 3%. But based on the current recommendations, now Roberta would be recommended pharmacologic therapy. So the take-home message is don't rely on your radiology sites who may report this number when you do your DEXA. It's something you should get comfortable doing yourself or having one of your assistants do this on your patients, because it can really help direct who should receive pharmacologic therapy or not if they're in that osteopenic range. And that's very important. This is only meant for postmenopausal men and women over 50. It's not for younger patients, and it's not for patients who already have a diagnosis of osteoporosis or if they're already on pharmacologic therapy. It's not for monitoring. What it's done is to help you determine who should be treated and who does not if they're in that osteopenic range. And again, you could use either the femoral neck BMD or the total hip, whatever you have available on your bone density report. If you don't have the report, you can do it without, but if you do, it automatically eliminates secondary causes of osteoporosis in the calculation. So what's the take-home message of FRAX? It really helps you, just like the cardiovascular risk, should I put a patient on a statin or aspirin or not, it helps direct which patients should get pharmacologic treatment, which should not. You do have to have either an internet connection or have it on your smartphone, because if it's not around in real time, it probably won't get used. Some things don't make total sense. You mean if a patient had past steroids, it counts, but if she stopped smoking a week ago, it doesn't. So you need to use a little common sense when using it. There are other risk factors, as you note, that are not included in FRAX that makes it not the perfect test, just like the cardiovascular risk test doesn't include diabetics or obesity or other factors. And again, you might say, well, a 3% 10-year risk, that means there's a 97% chance she's not going to have a hip fracture. So this is for shared decision making. Your patient might say, well, I'm willing to accept that risk. Or like Roberta, I don't want to wind up like my mother with a hip fracture. 3% might be significant to them. Also, like I said, be careful when it's entered in radiology reports, because some of the time the information they put in is not accurate, and they'll often report FRAX even for patients with osteoporosis or already on therapy. And as I mentioned, this is only to be used for that osteopenic patient to decide whether to prescribe initial therapy or not. So hopefully that helps those of you who weren't sure or had a different answer, but the right answer for this patient would have been to conduct a FRAX because she's in the osteopenic range. Now, what is the main reason that you don't utilize a FRAX currently in your practice? Is it lack of access to the tool when you're seeing your patient? Maybe you don't have computers in your rooms. Time constraints, lack of familiarity. I know some of you weren't familiar with this until now. Would you not, you don't think it would really make a difference in your treatment decision, or you already are doing it? You're already a FRAX champion. So please pick your option now. Okay, so I'm really glad that I went over this, and hopefully I'll get some feedback if I've made this clear and maybe something that you can test out on your patients, because I see most of you are not familiar with this, and hopefully that's a good take-home for you. And then there's another majority of you are already using it, and hopefully maybe you can comment of whether or not you found that helpful. I do know some of you still might not have access, and hopefully, loading it on your smartphone might help with doing that. So what about treatment? So you have Roberta, who is now, because of her wrist fracture history, is a candidate for treatment, or she had overt osteoporosis. What are our pharmacologic options? So if you have Roberta in your office and you go over her FRAX result with her, what are you going to recommend? Are you going to recommend estrogen, bisphosphonate, raloxifene, teriparatide, or denosumab? So please put your answer in now. So most of you picked bisphosphonate and a much smaller number raloxifene, but none picked teriparatide or denosumab. That might be also maybe your familiarity with those. and a portion of you picked estrogen. So let's go over each of these therapies in more detail. So when we look at FDA-approved therapies, pharmacologic therapies, they're usually broken down into medications that reduce bone turnover, and those include the bisphosphonates, the SERMs, calcitonin, and the REG ligand inhibitor denosumab, or the anabolic agent teriparatide. And you can see there's only one in that class. If you notice, estrogen is not listed in either of these. Estrogen is not FDA approved for treatment. However, we do know that for most postmenopausal women, probably like Roberta, the main reason besides age that she is suffering from osteopenia is the fact that she's estrogen deficient. So if you have a symptomatic patient who does not have overt osteoporosis, you can use estrogen and you may find a slowing of their bone loss or improvement. But in asymptomatic patients, it is not recommended and is not recommended first line. So let's go through these other options. I'm also not going to discuss calcitonin. Calcitonin has not been shown to be effective for treatment, so it is very, very rarely used anymore. So let's go through the other options. Most of you had picked a bisphosphonate. I think that's probably because most of you have the familiarity with it. Bisphosphonates work by killing off osteoclasts. Osteoclasts are the Pac-Men that chew up bone. And up until age 30, you have a nice yin and yang balance between osteoblasts that lay down bone and osteoclasts that chew bone. But what happens is as you get older, you start to get an imbalance, and certainly with estrogen deficiency that gets accelerated, or certain medical conditions like hyperparathyroidism or steroids will accelerate, will put those osteoclasts and make them hyperactive or make a lot more of them, and the osteoblast can't keep up and you get net bone loss. So what the bisphosphonates do is they kill off the adult osteoclasts and they give time for the osteoblasts to again go and fill in bone. They don't, though, stimulate bone growth. So you can see slight increases in bone density because it allows those osteoblasts that are left to fill in. But it isn't truly bone stimulating. And that's important because what you look for with bisphosphonates is a decrease in bone loss. You don't necessarily have to see an increase in bone gain when you do bone densities on these patients. Alendronate, residronate, and abandronate all come in oral formulations, but zoledronic acid is an infusion that's given over 15 minutes once a year, and abandronate also has an IM formulation. The important thing is to understand that if you have a patient who has low bone mass or osteoporosis at the hip, abandronate has not been shown to be effective at the hip. So it usually comes down to personal benefit. Alendronate and residronate are very inexpensive. They come in once a week or once a month formulations. Alendronate is a once a year infusion. Abandronate is also once a month, but again, really want to be careful in your patients who have low bone mass at the hip. You do know that you have to take it on an empty stomach because it's very poorly absorbed. If patients take it with food or other medicines, they probably won't derive any benefit because it won't get absorbed. And also, if they take it with food, they may not get absorbed properly, and they could develop upper GI effects. It doesn't cause ulcers, but it can cause reflux. It's a bad irritant to the esophagus, which is very important that when patients take it, not only on an empty stomach, but that they don't lie down. So it gives time for the pill to go into the stomach and not sit in the esophagus to irritate it. There are some patients who may get bone or muscle pain after taking it, but that's pretty rare. And we'll talk more about what people are most worried about, and that's osteonecrosis of the jaw or atypical fractures. I think what's more important to understand is, again, making sure patients take these medicines correctly. They're very inexpensive. They work very well, but they only work if they're taken properly. Empty stomach, I usually have my patients wait at least, it says a half hour. I try to get them to wait closer to an hour before taking other medicine or taking their food. I try to get them to take at least 8 to 12 ounces of water when they take it. If they develop some heartburn or irritation, I often will just stop it for 2 weeks and then restart it, and often their symptoms do not come back. But if it's persistent, then those are patients that I might try IV therapy like zoledronic acid instead. One thing to keep in mind that people forget is none of these are recommended for anyone with a GFR under 35. So if you have patients who have renal insufficiency, you need to be very cautious about using it. Also, the first time you give the IV therapy, they may get flu-like symptoms, so giving Tylenol or ibuprofen beforehand can reduce that. Osteonecrosis of the jaw gets a lot of media attention, but number one, it's a very, very rare condition. Nobody dies from it, and it is very treatable. It's a condition where you get unhealing, non-healing necrotic bone, usually in the jaw region. There is an association with patients who have used bisphosphonates. However, they tend to be patients who get high doses of bisphosphonates for cancer treatment. Bisphosphonates are used for patients with metastatic cancer to prevent hypercalcemia and reduce bone pain. And in those patients who are already immune compromised, they have a higher risk. But in our patients who are actually using it for osteoporosis, their risk is very low, somewhere between 1 in 10,000 to 1 in 100,000. So again, a very rare condition for most of the patients that we're going to be treating. What are some common sense things that you can do? If you have a patient, we should all be talking about their dental health. Have them see their dentist, find out if they need any dental work prior to starting them on a bisphosphonate. But once they are on it, I don't recommend stopping it. These medicines stay in bone for long periods of time, so stopping it probably will not have any beneficial effect. But most important is reassuring patients that it's a very, very rare condition, and if a patient gets it, it's very treatable. You also may have heard of atypical femur fractures. These are even rarer events, less than 1% of all hip fractures that occur. There has been some association with patients taking alendronate, probably because alendronate's been around longer, but taking it for more than 5 years. There's really no other obvious association. One of the theories is that maybe it causes marked decrease in bone turnover to the point that now you get microfractures, but it's still not very well understood, very, very rare. The point is, if you do have a patient who's on a bisphosphonate for a couple years, if they come in complaining of thigh pain, that's a patient you want to get an x-ray right away. If you see widening of the calyces, that could be a warning that they're at risk for an atypical fracture. So again, very rare. We'll talk later about maybe when to stop bisphosphonates. And if you do have a patient on a bisphosphonate, comes in complaining of upper thigh pain, that may be a patient you want to get an x-ray right away. But again, very rare compared to how many patients benefit from these medicines. Drug holidays. There are some studies that if you have a patient who hasn't already suffered a hip or a vertebral fracture, and they're on their bisphosphonate and they're doing well, their bone densities have stabilized. Remember, they don't have to increase, but they're not decreasing significantly. There are several studies based on alendronate, risedronate, zoledronic acid that showed that if you stop those medicines after 5 years, many of those patients continue to benefit because that medication stays in their bone for several years. So this is an option I do offer my patients, but those who haven't already had a hip fracture or vertebral fracture, those patients who tend to have improved or stabilized bone density, I offer to stop after about 5 years, and then I follow their bone density or their CTX levels, make sure their serum CTX isn't rising or their bone density isn't dropping, and if it does, talk to them about restarting their medication. So if you have patients who have trouble affording these medicines, or say I'm not having any symptoms of my osteoporosis or I really have to stay on it forever, a drug holiday may be appropriate in those low-risk patients. Raloxifene is a SERM. It basically has the benefits of estrogen on bone without the risks on breasts and other areas. The nice thing about raloxifene, it's a pill you take once a day. It has been shown to help reduce vertebral fractures, but again, if you have patients who are at risk for hip fracture, it has not been shown to do that. Probably its biggest advantage is if you have patients who have breast cancer or a history of breast cancer, it's been shown in those postmenopausal women to not only reduce their risk for vertebral fracture, but reduce their risk for recurrent breast cancer. The problem is a lot of patients can't take it or tolerate it. They tend to get hot flushes and night sweats, and they're at the same risk for blood clots as women who take estrogen. And it is a pill that they have to take every day. But if you have a patient who has a history of breast cancer, this may be something, if you talk to their oncologist and they also have osteoporosis or osteopenia, they may benefit from. This is one of the newer agents I think none of you had selected, and again, because it's one of the newer ones, called denosumab. It's an antibody that binds to the osteoclast. So if you remember, I said that bisphosphonates kill off adult osteoclasts. This actually works much earlier. It keeps them from even maturing and multiplying. So it's very effective. It reduces both spine and hip and non-vertebral fractures. It doesn't cause the same stomach symptoms because it's a sub-Q injection that patients want. You do have to screen their renal contraindications. So if you have patients with renal failure, you can use denosumab where you can't use a bisphosphonate. So if you have patients who have GI intolerance to a bisphosphonate, they're not taking it properly because they can't remember to take it every week or every month, or you have a patient with renal insufficiency, denosumab may be a good alternative for those patients. But if you have a patient who has a T-score of -3.5 or lower, or they have osteoporosis -2.5 or lower, and they've already suffered a vertebral or hip fracture, using those anti-resorptive medicines may not be enough. They might require something that's also going to build bone, and that's what teriparatide is. It's actually PTH. You might say, wait a minute, I thought hyperparathyroidism causes osteoporosis, but if you give it in a small pulsatile way, that's different than patients with hyperparathyroidism. It actually helps build bone. It actually promotes osteoblast activity, and you can see significant increases in bone. It's only indicated for up to 2 years, so usually if I have a patient who has severe osteoporosis, it's a sub-Q injection that they take every day. It is very expensive, but after 2 years, I'm able to then switch them to either a bisphosphonate or denosumab, and can significantly reduce those patients' risk of a subsequent fracture. Now, it doesn't matter what you prescribe if a patient doesn't take it, and we do know that many patients don't continue to take these medicines, often something they should be taking for years, if not for a lifetime. So it's very important to see your patients back on a regular basis. So real quick, what do you think is the reason in your practice that your patients may not stay on their osteoporosis regimen? Is it cost? They don't think they need the medicine, they forget to take it, they don't refill it, side effects, or you're not sure? Please pick one. And let's see what everybody has to say. And it's all across the board, and that's no surprise. There are many, all of these are reasons that many of our patients don't stay on these medicines. So if we could go to the next slide. So there are a couple strategies that I recommend with patients. If you find that they're not able to take it properly or there's side effects, hopefully now you're aware of other options for those patients. Also bringing them in more frequently, making sure they understand why, because if they have no side symptoms of osteoporosis, sometimes they need reminding about why it's important to take it. Also extending their regimen. If they can't remember to take something every week, can you put them on a every month bisphosphonate, or get them an infusion of an annual one? And any kind of electronic reminder to get patients back in to recheck how they're doing, not just waiting every 2 years to get their bone density. Also, if they need some other encouragement, doing a bone marker study to show that their medication is actually working if they take it. Very important, obviously, that we talked about exercise. It might not improve bone density a lot, but it strengthens their muscles, improves their balance, and has been shown to be a great way to reduce fractures. We certainly always worry about falls. It's hard to break a hip unless you fall. So we do here have some strategies that I encourage you to review and to promote to your patients, because most patients fall in the home, and if you could make these recommendations, the best Christmas, Hanukkah, or Kwanzaa present you could probably give your patients is doing a home inspection or having a significant other do that to help reduce falls. So I want to take this time to open it up to any questions that you may have and see if there's anything I could clarify that I've gone over or assist you with.
Thank you, Dr. Levine, for that excellent presentation. I will now begin reading questions that have been entered into the question box. So our first question is from Susan, who asks, are vitamin D and D3 equally helpful for osteoporosis prevention? And if a patient swims or cycles, how much weight-bearing exercise in addition to those weekly ones and should they do, and does walking count towards that exercise?
I try to handle one of these. I guess she meant, is D2 or D3 the same? I'm on my ergo versus cholecalciferol. Vitamin D3 gets absorbed about 3 times better than vitamin D2, so I tend to recommend vitamin D3. It's not more expensive, but in all honesty, there's no evidence that one is actually better than the other at preventing bone loss or reducing fracture risk. Remember, patients in clinical studies for treatment all got calcium and vitamin D, so when you see placebo arms and patients still fracture, that means that calcium and vitamin D alone is not enough. If you have a patient who meets the FRAX criteria or has osteoporosis, in addition to calcium and vitamin D, they need treatment. However, you definitely need calcium and vitamin D for all patients, one, to prevent bone loss that puts them at risk, and once they're on treatment, to help the medications work better. So no, I say you could use vitamin D2 or 3. I tend to use cholecalciferol because it's easy to find, it's just as cheap, and maybe absorb better. Walking does count. Anything that's considered weight-bearing. Jumping is better, so if they can do Zumba or step exercises, will tend to put more pounding on the bone and stimulate bone growth a little bit better, but walking certainly does count. You know, we do recommend 30 minutes at least 5 days a week for aerobic activity, and really the same for bone density as well.
Great, thank you so much. Our next question is from Rick, who asks, is there anything a patient should do when on steroids to combat the negative effects, such as an increase in calcium and vitamin D?
Excellent. Yes, you want to make sure they're on calcium and vitamin D. The most important is making sure their specialist is aware of their risk. There are current recommendations from the Association of Rheumatology that patients who are on chronic steroids need to get bone densities sooner and often need to be monitored a lot closer. So if they have osteopenia or osteoporosis, instead of every 2 years, they might need to get a DEXA every year. That's one of the few exceptions that you often can get insurances to cover a DEXA. I don't recommend doing it sooner except in those patients. But the most important is making their specialists aware that they're either at risk or are already losing bone, and to try to get them off their steroids. There are so many new steroid-sparing agents for all conditions that we use steroids, but very often specialists forget about osteoporosis as a potential side effect. So getting that appropriate patient on steroids screened, if you identify that they're losing bone, making sure their specialist is aware, see if they can get on a steroid-sparing agent or be followed a little closer, and if they need to go on osteoporosis medication, to do that if they have to stay on their steroid agent.
Perfect, thank you. That's all the time we have for questions today, but if anyone has any additional questions that we didn't get to, please do feel free to email them to us at education@arhp.org, and we'll display that email address in just a couple more slides. Dr. Levine, would you like to review the key points before we conclude?
So first, I want to thank all of you for your participation. Your questions were excellent, and I'll make sure that if you reach out with other questions that we'll try to get those answered. But really, hopefully you got an understanding of why osteoporosis is such an important issue for your female patients, and why it's important to screen your patients, both for their non-modifiable and modifiable risk factors, making sure that you, all your women 65 and over get a DEXA, and if your patients who are postmenopausal but under 65 meet the criteria, that you get them screened as well. Also, once you've made appropriate diagnosis of osteoporosis, or if they're osteopenic and you perform a FRAX and they meet the criteria, that those patients get screened for secondary causes, and if they meet the criteria for treatment, that you go over and review their treatment options and find the one that best suits the patient's need. That you utilize strategies to check on the patient, make sure that they're staying on their medicine, that they're tolerating their medicine, and all important is to also include both exercise and fall prevention in your guidelines and strategies that you use for these patients. And with that, I want to wish you and your families health and happiness, and to all your patients as well. Thank you.
Thank you, Dr. Levine, both for joining us today and for talking so eloquently about the importance of incorporating osteoporosis care for postmenopausal patients. Before we end today's webinar, I'd just like to share a few additional reminders. Please be sure to visit arhp.org, where you can find the on-demand version of our first webinar in this series on osteoporosis in premenopausal patients. The recording of today's webinar will also be posted on arhp.org within the next week. As a reminder, you will receive an email from Caitlin Borzowitz in about an hour containing a link to the post-test survey. Your SAME or nursing e-certificate will be generated at the end of that survey. Be sure to print the certificate before closing your internet browser. If you have questions, please feel free to email us at education@arhp.org. Thank you again for joining us today. We hope you will take part in other live and on-demand sessions hosted by ARHP.